the classical is that there's a disruption in consciousness and ongoing states of consciousness. And so therefore, when the infant, let's say now, is in hyperarousal and literally is at the limits of the sympathetic nervous system, can drive it, the heart rate is up, etc., at the limits, what you'll see is that you'll see the system shut down at that point in time. The infant now stares off into space with a blank look, literally at that point is gone. Well, there is a discontinuity in that baby's state of being. At that point in time, the baby is not processing anything from the outside world. It's not processing cues coming in from the caregiver. It's not even processing its own bodily cues coming up. It's in this low metabolic state. So here, the new piece of information that I think also needs to be made here, and it's interesting, there are pieces that can go from one work in one area of psychopathology which can be directly applied to another. In the area of dissociation, there is now a move into not only cognitive dissociation, like fugue states, etc., but somatoform dissociation. Somatoform dissociation is the individual now is cut off from their body. They cannot read the internal rhythms and flows of their own body, which I would suggest to you that in the severely empty core of the suicidal state, cut off from the body, they can't even read that. That becomes extremely dystonic, extremely negative influence. So here's the matter here of being with a patient and talking about these themes, and all of a sudden, patient's gone. All of a sudden, being able, therefore, for the therapist to be able to track even low levels of massive disengagement would be critical. If you don't track them, essentially, they'll build an intensity, and then you're dealing with a massive situation here. So again, massive. But what does it mean, again, about being able to track your own heart rate when it's dropping, etc.? How do we pick up dissociation? So as we talked about before, again, this brings the body into the work. And I'm really, I have to say, that in the case of the field of suicide, there was an understanding now for some time, as you just pointed out, that the body is severely dysregulated, that is part of this problem here, that the field of suicide never did go too overboard with the cognitive, because they knew that the body dysregulation was a key to that piece there, and that's critical, and that is therefore reinforced. That is reinforced now by the current neuroscience. Well, the hypoarousal, literally when one is in the hypoarousal for so long, you have with borderline personality disorders, in the states of hypoarousal, not only is there no processing of the body, but the pain sensitivity is severely altered. So the pain threshold is increased, which is why that in the dissociated state, there's no physical pain. For borderline personality disorders to come out of that state, they'll cut. And it's essentially to literally bring the sympathetic nervous system back online. Let me say it again here. In the most severe end of the suicidal crisis, the sympathetic nervous system is hardly operating. It's all the dorsal motor vagal parasympathetic system, etc. And so you're not even getting that swing, and cortisol is low, etc. So here, yes, and this also gives us an understanding of why there are those swings as the person is now attempting to auto-regulate themselves out of deep hypoarousal. And it may very well be that the action, quote, the action, because if the self is in an aggressive state, there still is some semblance of a self. When the self is in a collapsed, empty state, there is no semblance of that. So it's better to generate some form of hyperarousal, which incidentally could also be done with certain drugs, which we haven't talked about. That could also be parts of these kind of situations. I had mentioned somatoform dissociation. So in the cases of somatoform dissociation, where the person is cut off from the body, this has been studied by the trauma researchers in Holland, and what they found is that in almost all of these cases, there is early relational trauma. Specifically, there was abuse in which the child was hit. There was physical pain. Incidentally, the attachment relationship even sets over the threshold of the pain system also there. So we're talking about here the later consequences of an infant being hit. Now remember, I want to point this out. we're not talking about single incidence trauma in this whole model. We're talking about chronic ambient trauma, whereby attachment trauma over the first year or two of life, the caregiver and the infant were constantly out of sync with each other. The baby was in high densities of negative affect, perhaps if it was hit in pain, the time, etc. So we're not talking about a specific reenactment of a specific traumatic situation. We're talking about cumulative trauma, chronic, and that will be repeated again. That will be repeated again with the expectations of it. And the expectation would be that at times of the most severe distress, if one went to the caregiver, if one opens oneself up and is vulnerable, one will not find safety and comfort. One will get further dysregulated. And that literally is built into their expectations. And that's what one is attempting to try to change. Incidentally, the fact that we're now looking at earned secure attachments, which means that even with horrific early histories, they can be altered by later life experiences, by connecting up with better affect regulators, would clearly mean the attachment can be altered. And if that is so, that would also mean that the type Ds, let's say, who are suicide, also could be altered in long-term work. In the case with someone who has never had that, in the case of someone who has never forged a bond of interactive communication and attachment with another human being, it would take a while to come to that, which is why 6 sessions is not necessarily going to do this kind of work here, and it will be a longer-term situation. That said, there are now a number of studies showing in borderline personality disorders, as severe as this, that psychodynamic models that are working on 2-3 years definitely are altering the trajectory, definitely are changing the symptomatology, etc. So we now have efficacy studies there. But yes, this is not short-term work with these patients, and therefore what you find is these patients will loop in and out of therapy, over and over and over again. And I want to say again that in part, perhaps part of the problem has been that we have, because our models have not been as complex as they need to be, and they really haven't outlined the internal psychic structure and the internal world here in terms of the biology of it. We really haven't been able to form models that are based on it. But now, as we move forward, I think for the first time we have kind of psychobiological models which are complex enough now that would lead us to a different approach to therapy, a more complex one, a deeper one, but also essentially heightening the affect and the affect regulation of them. And I think, therefore, these models will ultimately, lead to more efficacious treatment also. But remember that essentially attachment is interactive regulation. So attachment is affect regulation. I mean, essentially the internal working models of attachment are encoding strategies of affect regulation. And of course the internal working models, as Bowlby said, are unconscious. And so essentially that's what the attempt is to change, not conscious models, which is why therefore too much of counseling, which is just focused on the surface, which could work very well with more complete personalities, it's going to be fine. But frequently, let me point out here, because the higher structures of the right hemisphere really never did form in the first place, these patients are not necessarily psychologically minded. I mean, by definition, they're not. And so essentially what we're looking at is a structure, a therapy which can ultimately allow for the creation of a structure by which the patient can then now for the first time have the reflective capacity to reflect upon the affects within. So for that reason, again, because insight never was an effective treatment, we can now understand why insight wasn't. And I would suggest still is really not the heart of this, really is more of an affect regulation model than insight model.